Thank you all for joining us. Good morning, good afternoon, and good evening. We are pleased to welcome you and the 196 participants joining us from countries around the world. Welcome to a focused session on rapid mortality surveillance and excess mortality measurement hosted by the Public Health Programs team at Vital Strategies. Vital Strategies is a global health organization that works with governments and civil societies around the world to tackle some of the most pressing public health challenges and problems. I am April Budd from Resolve to Save Lives, and I will be your moderator for today's session. I am joined by my colleagues Philippe Donze and Benjamin Clapham. Together, we will facilitate this session and your interaction through polling and through a structured Q&A. Please note that on the toolbar at the bottom of your screen, there is a box marked Q&A. We want to hear from you, so throughout the session, you can enter your questions into the box, and at the end of the hour, Benjamin will lead us through a structured Q&A to answer your questions. So today, we will engage in a session that is designed for anyone interested in measuring COVID-19 mortality. It will provide you knowledge on the core components of rapid mortality systems and direct you to the resources available, including the new technical package which will be launched this week. So before we get started, we want to know more about who is in the audience with us today. So shortly, we will run a poll that asks the type of organization that you are representing. At the close of the poll, we will then begin with our first speaker, Philip Settle. Dr. Settle is a medical anthropologist and social demographer. He currently directs the Civil Registration and Vital Statistics arm of the Bloomberg Philanthropies Data for Health initiative at Vital Strategies. To lead this discussion, he is joined by his colleagues on the Public Health Programs team, Martin Bracci, Carly Congdon, Robert Musuya, and Roxana Gina. So thank you, panelists, for joining us today. And now on to our first poll. Please indicate the type of organization that you work in so that we can see who's represented. You see the options before you: government, department, or agency, whether you work for a nonprofit or a non-governmental institution, an international organization, an academic or research institution, or a public health association. The poll should be in front of you now. Please click. I'm seeing that your responses are coming in. About half of you have responded, so we'll keep it up for a few more seconds. We'll allow 10 more seconds for the last remaining people to vote. We're at 80%. Okay.
So let's see those results.
All right.
Well, it's a good spread, very interesting. Welcome everyone to the webinar. We have quite a few international organization and nonprofit representatives, as well as government department and agencies on the line, as well as some academics and some public health folks. So we will try to address some of the natural interests that you may have coming from your various organizational backgrounds. Next slide, please. An evidence-based response to this epidemic is going to depend on knowing its scope, scale, and impact. Know your epidemic, know your response is as true today as it was in 2008 when UNAIDS coined the phrase. And yet we know at the moment that we're not really sure how many people have been lost to the COVID-19 pandemic. We believe that every country should really know the scope and scale of its epidemic in real time as much as possible to guide an evidence-based response. Next slide, please. So what is at the root of this uncertainty? There's an uncertainty of numbers that really has been documented very actively in the press. We have stories about what is and isn't or aren't the correct measures of coronavirus, novel coronavirus, COVID-19 deaths and cases. And this uncertainty has been covered in the press and discussed quite a lot in public health circles. Next slide, please. And this uncertainty, in large part, stems from a lack of testing. We are acutely aware that testing is usually restricted to clinical settings in many country contexts. And we're aware that this is a situation in which many more non-fatal cases than can ever be confirmed by a test are actually occurring. But how many are there? This is part of the ambiguity around defining and counting COVID-19 specific cases. But deaths are also ambiguous to count when attributed to COVID-19. This is complicated further by the fact that while WHO has been very quick in releasing emergency ICD codes and coding rules about the International Classification of Diseases, that's what ICD stands for, and the proper way to certify causes of death, these will take a bit of time to do the necessary training and upskilling and dissemination of guidance so that there can be proper application of these WHO guidelines. And this is going to take a little bit of time. Systems that aren't fully digitized, hospital information systems that aren't fully digitized, may also take some time to produce data, even if these new standards are being applied rigorously. Next slide, please. But the problem is that this focus on hospital testing and identifying cases at hospital and clinical settings and so forth may miss a very significant part of the picture. In low and middle income countries, it's not uncommon that the majority of deaths are occurring at home. In many countries, this is the norm. In some places, up to 70% of mortality. This is before the epidemic. Up to 70% may have been taking place at home. Under the conditions of the pandemic, this may actually increase. We don't actually know at the moment how much it may be increasing, but with overstretched healthcare systems, with changes in care-seeking behavior, there may be an even greater burden in the community, if you will, or outside of the hospital setting where it would be easier, in a sense, to count all deaths. So there needs to be some means to account for this community quotient of mortality as well. Next slide, please. Taking this uncertainty, this context of uncertainty, the challenges of measurement, and the need for data all into account brings us to the idea of rapid surveillance of all deaths during the pandemic. This provides an awareness, as I will show you, of the trajectory and the distribution of the health impacts that are associated with and occurring during the COVID-19 pandemic. And it does so, we believe, with speed and simplicity, detecting all deaths by age and sex, and wherever possible, leveraging existing systems so that we're not starting from scratch and building something to generate these data. One advantage of focusing on all deaths is that it avoids this measurement ambiguity I was alluding to and discussing earlier in my conversation with you. And it avoids this delay that may take place in attempting to overly specify whether a death was due to COVID-19, suspected due to COVID-19, or due to another particular cause. At the same time, our idea of rapid mortality surveillance does permit the use of cause of death data where they are readily available. So it should not be seen as in any way, shape, or form interfering with the assignment of cause of death using routine systems. This should certainly continue. And lastly, I'd like to say in this part of my talk with you that rapid surveillance of all deaths is sensitive to this contribution of secondary or indirect COVID-19 mortality. Again, I will show you an example of how that looks. Next slide, please. On this graph, you see data from Brazil, from an actual municipality in Brazil for the first 17 weeks of this year. The graph maps total mortality in the dashed line, which you can see starts to climb dramatically in about week 13 or 14. I want to stress that this focus on total mortality alone would be a compelling picture, but when you add an historical perspective, even just last year's mortality, which in this graph is conveyed by the solid blue line along the bottom of the graph until week 13, and you can see it deviates from the total mortality to give a picture of the excess mortality. That excess mortality, that additional amount of death than would normally be expected, is what we refer to as excess mortality. And this excess in mortality can be measured and tracked. Next slide, please. It can be measured and tracked in a way that gives us a chance to see changes from historical norms. It aids in understanding, for example, when to implement or relax public health social measures, such as social distancing, or something more stringent, such as stay-at-home orders. As you can see from the graph that is on the right-hand side of the screen, it captures deaths that might have otherwise gone uncounted, because these are the total number of deaths occurring in 2 age groups, as shown in the slide. And lastly, while it should be noted that mortality is a lagging indicator, from the time of infection to the time of death could be as much as 4 to 6 weeks, easily. To the time of reporting could be easily 4 to 6 weeks. It nevertheless does provide a solid evidence-based accounting of the mortality occurring during the pandemic. Next slide, please. Just before moving on, I want to show you what it might look like were we able to show a graph of total mortality. That is this solid dark line that goes up like a mountain at the right-hand side of the screen. That's the estimated all-cause mortality for New York City between January and May of this year. Were we to have focused solely on the COVID-confirmed mortality, we would only be getting about half of the picture, as indicated by the darker columns on the right-hand side of the screen. Adding in suspected COVID mortality only gets us a little bit further when we're accounting for cause of death specifically in understanding where excess mortality is coming from. So I believe that this graph is a very powerful illustration of the need to focus on total mortality when understanding the excess death that is occurring in the epidemic. Next slide, please. I'd like to take just a moment. You saw the logos of our partner organizations in developing the technical package that you will be hearing about in the rest of the webinar. The names of the organizations with whom we have partnered are on the screen, and I just want to take a moment to express my really deep appreciation and excitement about the technical package that will be launched later this week in collaboration with the organizations that you see on the screen. Next slide, please. Next slide, sorry. I want you, as we go along, not necessarily for the Q&A section, but just for your own thinking about this technical package and the model of rapid mortality surveillance we're discussing. What components of this model might be most applicable in your settings? What would be most difficult to apply? What systems could be leveraged, perhaps, to implement? And does the model strike a balance between feasibility, technical rigor, and speed? Remember, timeliness is really key here. Are there gaps and ambiguities that you notice that we might not have accounted for that are highly relevant in your local situation? So for yourself, please, we invite you to think about these kinds of issues as you listen in. Next slide, please. I'd like now to hand over to Martin Bradshaw, our Technical Deputy Director in the Data for Health initiative supported by Bloomberg Philanthropies. Martin is going to discuss with you a description of the rapid mortality surveillance system that we are advancing here and some of the key considerations that are involved in that. Martin, over to you.
Thank you very much, Philip, and welcome everybody to this webinar also from my side. So I'll just be, as Philip indicated, I'll be talking a little bit more in detail about the rapid mortality surveillance system, which we're outlining in the technical package that will be released later this week. The rapid mortality surveillance system can collect information about all-cause mortalities, so that means all death, from facility-based reporting, so from health facility, from community-based reporting, or from reporting from the medical legal death investigation system, in settings where that system plays an important role in collecting information about the occurrence of death. From all of these systems, it's possible to collect information from complete enumeration or from sentinel sites. Timely information collection is very important here. Therefore, the information from these sources should be transmitted on a daily or weekly basis to the central level, for example, to the Ministry of Health or to other government agencies. Here, the information can be compiled, quality control steps can be done, and then the data can be compared to the historical baseline, as illustrated by the example shown by Philip. Together with the historical baseline, the information collected on an ongoing basis can then be presented for decision-making. Next slide, please. Let's look at a few fundamental questions. As a first one, we think it is of great importance that there is full buy-in to such a system from government, that government systems are used to collect this critically important information, and that there's full ownership to the rapid mortality surveillance system. In terms of scope, as mentioned above, the reporting can come from facilities or from communities or possibly from both to ensure that all death can be counted from the sentinel sites. In terms of coverage and timeliness, as Philip has also alluded to, it's very important to try to build on existing systems and capture death. This may be the civil registration and vital statistics system in some setting, but other systems should also be considered. What's really important is that under these difficult circumstances, it will be very challenging to build a system specifically for this purpose, and that's actually also not our intention. However, it's important to build on existing systems that capture reports of death and are able to report about individual death by age, sex, and location on a weekly basis, so in a very timely fashion. In terms of cause of death information, it is possible to add cause of death information to the rapid mortality surveillance system. This may be particularly feasible when reporting happens from health facility. However, it's also possible for community reporting, and we'll have a bit more of a discussion around that point later on in the webinar. And finally, a really important point that we also want to stress is that anyone involved in data collection that has direct contact with individuals and has to investigate these deaths should be given the appropriate personal protective equipment. This is really critical, especially, of course, at a facility setting, but also in communities if this data collection is done in person. In the technical package, we also outline the option of collecting this information from the communities by telephone, if that is feasible. Next slide, please. A few additional system considerations. So as I mentioned above, the system can either have full enumeration or be based on sentinel sites. If a sentinel site approach is used, it should be ensured that the sentinel sites are representative of the population, and additional sites may be added to focus on vulnerable populations. As we are suggesting a system for very rapid and timely data collection, we would like to stress the importance of focusing on a few key variables. The ones we are recommending are listed here. They are date of death, age at death, sex, location of usual residence, and place of death, that is inside or outside of a health facility. As also mentioned above, we'll have a bit of more of a contribution on this later on. It's very important that these systems will also require historical estimates of baseline mortality. This again can come from the civil registration system, especially if that system is well digitized, but it can also come from other sources. And finally, on cause of death information, this may be added, but feasibility will need to be evaluated on a case-by-case basis. Next slide, please. Okay, so with the information collected above, it will be possible that the information that I mentioned, if that is collected, it will be possible to calculate the number of deaths by age, sex, and location. By combining this observation of current mortality with the historic background, it will be possible to determine the percent deviation from the historic or estimated average number of deaths in a given period of the year. This data can then be disaggregated by sex, by age groups, and we are recommending the age groups listed here, realizing that COVID-19 mortality mostly affects older aged individuals, can be disaggregated by location of usual residence and by place of death. Again, that is inside or outside of the health facility. And as we are outlining in the technical package, if a facility-based surveillance system is used, it will be important to also track hospital admissions, as obviously the number of hospital admissions can affect the number of people that die in a health facility. Next slide, please. So let's have a look at what this may look like in country case studies. For that, I would like to hand over to my colleague, Carly Congdon, who will talk about a few country case studies. Thank you very much.
Thank you so much, Martin. With support from the Bloomberg Philanthropies Data for Health Initiative and COVID-19 response, Vital Strategies is supporting rapid mortality surveillance in 6 countries and in the process of expanding to new areas. As both Philip and Martin have said, the approach is tailored to leverage existing civil registration and vital statistics systems and equip them to produce good quality all-cause mortality data, with the goal to produce weekly estimates of excess total mortality by age and sex, as recommended in the technical packages. Some of these countries are doing both facility and community-based surveillance, while in some it's been most efficient to focus on just one of these systems. I'm happy to share 3 examples today from Bangladesh, Colombia, and Rwanda. Next slide, please. In Bangladesh, the government is leveraging community sentinel sites in all 8 divisions and 13 sub-districts that use the Kalaganj model to collect data on and information on births and deaths. Under this model, health assistants connected with the communities are notified of deaths when they occur. In the context of COVID-19, this could be through working at community clinics that remain open for immunization or other essential services during the pandemic, via mobile phone, or perhaps while just doing routine work in their communities. These health assistants then serve as notifiers at the local registration office, which ultimately leads to the aggregation and digitization of all-cause mortality data at the sub-district level, which is then reported to the central level. And in addition to routine demographic data such as age, sex, and date of death, during the pandemic, a list of systems will also be reported for anyone who had been tested for COVID-19 prior to death. This data collection is currently ongoing in Bangladesh, while we work with the government to establish historical baseline data from which excess total mortality for these sub-districts can be examined weekly by age and sex. Next slide, please. In Colombia, a somewhat similar community-based system called Colombia Rural Vital is used to collect information on deaths nationwide. With this system, community leaders report deaths to local health officials using a mobile SMS platform. Upon notification of the death through this system, health officials verify the death over the phone, and this usually involves the collection of standard demographic data, but during the pandemic, Colombia has also adopted a set of screening questions developed by the World Health Organization, which you'll hear more about later in this session, as a means to determine if a death may possibly be attributed to COVID-19. This information is transmitted to the municipal and central levels of the Ministry of Health, where daily reports of mortality data can then be produced, and excess mortality can be calculated using historically expected baselines. During the pandemic, this information will also be sent to the National Coordination Center and Epidemiological Intelligence Units, where COVID-19 suspected deaths can trigger additional follow-up or contact tracing as another element of response. And it's also worth noting that while this main system is used to capture data on just community deaths, cause of death investigations are also taking place in health facilities in Colombia, using a standard questionnaire to investigate probable COVID deaths as a method of quality assurance for health facility data. And lastly, in Rwanda, next slide please. Vital Strategies is planning with the government to leverage the robust systems that already exist for both community and facility-based surveillance. In facilities, a main component of this will be to improve the integration of the health information system, which in this case is DHIS2, and the integrated disease surveillance and response framework to report not just on morbidity, but mortality as well. The frequency of data transmission will also be increased to a weekly basis. And in addition to all-cause mortality, Rwanda is also looking at cause of death investigation in conjunction. So Vital Strategies will provide guidance and support to the government for the introduction of the 2 new WHO International Classification of Disease codes for COVID-19 into the coding system, so that this cause-specific data can also be analyzed and reported from health facilities. And to capture community deaths, Rwanda also uses a network of community health workers who, once aware of a death in their community, report that information to their health facility leader. The health facility staff then validate the demographic details of the event, input the data directly into the IDSR to be transmitted again to the health information system DHIS2. And to allow for rapid mortality surveillance, this system will also be improved to collect all-cause mortality data in addition to just morbidity. Both the facility and community-based systems in Rwanda have the capability for real-time validation. So with this increased frequency of transmission, the data can be aggregated and compared against historical baselines for weekly estimates of excess total mortality, also by age and sex. So as you can see, our ability to describe excess total mortality depends upon establishing some projection or historical estimate as a comparison. Here to briefly walk us through that topic is Robert Musuya, Senior Technical Advisor for Verbal Autopsy at Vital Strategies.
Thank you, Carly. As my colleagues have mentioned earlier, to understand the burden of COVID-19 on mortality, there is a need to have a baseline or historical data. This can be used as comparator for deaths that occur in health facilities, as well as that occur in communities during the COVID-19 pandemic. I will first talk about getting historical data from health facilities. In order to calculate the indicators related to excess mortality from facilities, observed mortality data from facilities during the COVID-19 pandemic will need to be compared to historical data coming from the same facilities. The historical data can be obtained from existing information systems in the countries, such as the District Health Information System, commonly known as DHIS2, which is implemented in many countries, or from systems like the SINADEF in Peru. 4 to 5 years worth of weekly historical data by sex and broad age groups will need to be collected. In addition, observed versus baseline facility level mortality data would be compared relative to the number of hospital admissions where possible. Therefore, admissions data, if available, is recommended to be collected to help with the interpretation of trends. We have put together a generic data collection template for countries to use in compiling weekly historical data from the health facilities in the last 5 years, from 2015 to 2019, prior to the pandemic. Also, on the same template, we have included collection of current hospital admissions to facilitate the excess mortality calculation and other comparisons. These templates are available for download with the links indicated in the Rapid Mortality Surveillance Technical Package that will be available this week. Next slide. I will now talk about approaches to obtain historical data on deaths occurring in the communities. Again, in order to facilitate calculations of excess mortality and other indicators for deaths that occur in the communities, historical data on mortality from communities are required for comparison. In areas where good quality historical data on community deaths are available, by age and sex that is, these will be compiled and will serve as baseline data for comparison. However, in places where historical mortality data is not available, or if there are big concerns with regard to the quality and completeness of the data, alternative demographic approaches to determine expected number of deaths can be applied, and therefore use expected number of deaths as baseline instead of the observed data. For the rapid mortality surveillance, the yearly population and mortality data from the UN World Population Prospects published in 2019 will be reference population from which expected number of deaths will be determined using the age-specific mortality rates applied to the surveillance population and disaggregated by age and sex. This approach works well when the selected surveillance areas are complete administrative units with available estimated population figures and for which numbers of expected deaths can be generated. We have provided more details on the indirect demographic methods using data from the World Population Prospects in the Rapid Mortality Surveillance Technical Package that will be shared this week. We have developed country-specific templates that are already pre-populated with data from World Population Prospects for countries to use with this approach of calculating expected number of deaths. The collected and compiled facility-based and community-based historical data will be used as inputs into the calculation of excess mortality. Now, putting all these pieces together involves the analysis of excess mortality. At this point, then, I would like to hand over to Roxana Giner from our data impact team at the Vital Strategies to talk about this topic. Over to you, Roxy.
Thank you, Robert. So in essence, let's look at the excess mortality calculation. And it's basically the difference between reported and expected deaths. For COVID-19, this would then be the excess number of deaths to have occurred during the pandemic. So how do we obtain this information? For reported deaths, we could start collecting this information when the rapid mortality surveillance system is established. However, if data on deaths in the surveillance site are routinely collected and easily available, a decision could be made to start calculating excess mortality at a set time point. And this may even be sometime in the past. So, for example, we could look at when the first COVID-19 case was reported, or even look at a time when the outbreak was anticipated. For expected number of deaths, historical data are then used to obtain a baseline. And as Robert mentioned, when these data are not available, estimates can be obtained using the indirect demographic methods. And these are described in the technical package that will be made available in this week. So ideally, the data should be analyzed on a daily or weekly basis, but this obviously depends on the existing system and how easily the data is available in that time periods. The analysis should also ideally include sex and age disaggregation. For the purpose of our project, we have decided to use 2 large age groups, as mentioned previously as well in this presentation. So we know that the number of deaths can be affected by both changes in admissions for deaths that are reported in facilities and by the population size for all reported deaths. This can then be addressed by calculating excess mortality using a rate difference. So if we think about an example for in-facility surveillance, we could then, instead of using excess mortality in terms of just frequencies, we could then calculate this as a rate difference by the number of deaths per 10,000 admissions. Next slide, please. So excess mortality provides a number of useful insights. Firstly, it increases our understanding of the impact of deaths due to COVID-19 on the population and the healthcare system in general. Further analysis can also help to identify specific vulnerable groups. As we are aware, the elderly is particularly vulnerable to COVID-19, but within countries, we may also identify specific demographic populations, or even if we're able to look at different geographies, we may end up picking up specific vulnerable groups or high-risk groups in certain geographic locations. The data can also provide additional operational information, so we can start looking at this difference between current all-cause mortality and the expected range and look at whether it's increasing or decreasing over time. It also provides a greater understanding of this potential relationship between public health and social measures and mortality. And then finally, it may actually provide insights into disease surveillance gaps in general. So this information should be shared with decision makers using basic descriptive statistics and simple visualizations. We've seen a number of such examples in this presentation. This helps to easily inform decision makers and so that they can use it to inform further action. And now, to wrap up the discussion on cause of death investigations and a summary of the webinar is Philip Settle.
Thanks so much, Roxy. Next slide, please. Thank you. That's it. First of all, I just want to thank you all for bearing with us in our technical problems and for signing back into the webinar. We really appreciate it, and thank you again. I know that there's a strong interest, and I have seen questions in the Q&A section of the webinar about cause of death and cause of death investigation. There are just a few things that I want to stress about this topic. One is that rapid mortality surveillance, as we have been describing it, again, should not interfere with the routine attribution of cause of death data according to the new guidelines issued by the World Health Organization, the use of the International Standard Medical Certificate of Cause of Death, compliant with the International Classification of Diseases, that's ICD, and the proper way then of coding mortality due to COVID-19, either confirmed or suspected, and causes, specific causes otherwise. That said, there is a space within the rapid mortality surveillance concept, if you will, for 3 levels of death investigation associated with rapid mortality surveillance. Again, this, in the same way that rapid mortality surveillance should not disrupt the assignment of cause of death according to routine systems, the assignment of cause of death should not delay the timeliness of reporting on all-cause mortality. First of all, we have the opportunity to use something that we're calling screener questions. Screener questions being sufficient to compartmentalize deaths into either natural causes, unnatural causes, or suspected due to COVID-19. These questions are in the process of being validated, but they are actually the product of careful deliberation by the World Health Organization's Verbal Autopsy Reference Group. For those of you who do not know what verbal autopsy is a post-mortem caregiver interview. So it's an interview with the family members of the deceased who have cared for the person who has died and who have been able to observe signs and symptoms in the deceased in the period before death. These signs and symptoms are then elicited in a structured questionnaire that is coded by a physician or a computer algorithm as to the likely cause of death. And we have tools to analyze both the screener questions, those will be available through the technical package, as well as verbal autopsy, which is level 3 and is also available through the technical package. Level 2 in our schema really relates to the proper certification of cause of death with correct ICD coding for COVID-19 mortality. And that is a crucial function of the health system that must continue. Next slide, please. In summary then, I would like to just stress that rapid mortality surveillance for both observing total mortality and excess mortality should be implemented as a core surveillance activity in the epidemic response. It really needs to be able to produce as close to real-time data as possible to be relevant for decision making and should build on existing surveillance systems wherever possible. Again, we emphasize the use of historical data for excess mortality analysis. And ultimately, if you remember back to the beginning of the presentation and that curve showing total mortality in New York City and then the components of COVID-19 mortality, both suspected and confirmed, we believe that this bigger picture will really help account for the true impact of the epidemic on the mortality burden, a truer picture than case-based surveillance alone. Next slide, please. We want to wrap up briefly with a poll question. We will leave time for question and answer. I want to reassure you that if we do not get to your question in the time remaining, we will respond to all questions by email in a group. We'll send out a digest of the questions that have been asked but not answered during the webinar. I'd like, though, to wrap up before we turn to Q&A with a poll question. It will go up shortly. In your view, what would the main benefit be of implementing rapid mortality surveillance and examining excess mortality? Philippe, if we could have the poll up, I can briefly review the poll options. Would it be to gain insight into disease hotspots and possible outbreaks of COVID-19? To support the civil registration system in ongoing notification of deaths during the epidemic so that those deaths can be registered? Or perhaps it would be to produce reliable data to share with policy and decision makers on the directionality of the COVID-19 burden and its direct and indirect components. Maybe it's to use the number of deaths as an indicator for measuring the success of public health and social measures. Or perhaps it will be used to illuminate disparities in disease spread by understanding how it looks in different socially disadvantaged areas with respect to the mortality picture. So which would be the main benefit of implementing this system? And I think we probably will leave this up for just a second. Philippe, I'll trust you to put up the responses when we have a good quorum of respondents. And we'll leave it up maybe just another 5 seconds or so. All right, let's see how you're responding. Philippe, may we have the poll results? All right, so I think that it's a very telling statistic that more than half feel that this actionable evidence is a really important component of a well-informed policy environment and decision-making structure in the context of the epidemic. So we have over half of people who say that this is important to communicate to decision makers, with about another half spread out across the other options. And I think that it is useful to bear in mind that all of these purposes may in fact be served by the notion of rapid mortality surveillance in the context of the COVID-19 pandemic. I just want to, yes, thank you for that slide. This will be the URL for the technical package, a mock-up of which you can see behind the image. Please watch this space. We will also email you directly with the link when it goes live and when you can access the materials that have been presented here today. I'd like to wrap up now by handing over to Benjamin Clapham. Ben is a technical advisor with our Civil Registration and Vital Statistics program at Vital Strategies. Next slide, please. And Ben is going to help steer some of the questions you have asked during the registration process and online to the panel in the remainder of the presentation of the webinar today. Thank you, Ben. Over to you.
Thank you, Philip, and for all the presenters. We have some interesting questions that came in during registration as well as during the presentation. So we have about 10 minutes to answer some of these questions. The first question is for Robert. What guidance is there to determine community mortality from COVID-19?
Thank you, Ben. This question has somewhat been addressed during the various segments of the presentation. However, indeed, it's a big challenge to determine deaths due to COVID-19 in the communities, especially in low and middle income countries where a significant proportion of deaths occur outside health facilities. And also levels of civil registration of death are very low. And also there's inadequate information on causes of death. More so, issues related to availability of routine community mortality data, their quality and completeness add to the complexity. We hope that today's presentation and the rapid mortality surveillance technical package that will be launched this week will provide good guidance, considerations, and recommendations on approaches and tools for determining community deaths that may be attributable to COVID-19. Implementing routine mortality surveillance embedded with existing community-based surveillance systems in the countries will help generate set of data elements need to analyze excess mortality by age and sex. And administering screening questions will help flag potential COVID-19 deaths for further follow-up. Thank you, Ben.
Thank you, Robert. The next question we have is from Martin. Is it possible to help countries develop near real-time reporting capabilities?
Thank you very much for that question. I think it's a very important point, and obviously we are stressing here the importance of rapid reporting, and that's at times very challenging, especially also during the current circumstances. I think as we mentioned in the webinar, and as we're also outlining in the technical package, it's really very important to try to build on existing systems, to strengthen existing reporting systems and to increase the timeliness of those systems. With the technical package, Vital Strategies together with partners are available to answer some questions and to provide some assistance to try to evaluate in specific countries what may be feasible. But again, we will have limited availability for that, but please have a look at the technical package and then we can see if there's any open questions that remain to be discussed. Thank you.
Thank you, Martin. The next question that we have is for Carly. How best can we scale up mortality surveillance for COVID-19?
Thanks, Ben. Also a great question. I think as we've discussed throughout the presentation, one of the best first things to do is look at existing systems that can be leveraged with an eye for those that have the highest levels of coverage and completeness. After that, I think there are two main components that you're going to want to look at, which the first one would be ensuring that this system can measure all-cause mortality. As we discussed in the country examples, there are a couple ways that you can turn systems that perhaps were originally intended for disease-specific surveillance into systems that can also measure all-cause mortality. And after that, you're going to want to make sure that that component is able to provide this data quickly, ideally on a weekly basis. So to increase the frequency of reporting, there's a few things that can also be done, such as reducing the amount of data that's collected, abbreviating the validation processes, or simplifying data flows that can allow you to have that data more quickly to produce the excess total mortality, ideally on the weekly basis.
Great, thank you, Carly. We have another question from Martin. If you could try to help us explain a bit more the link between CRVS and rapid mortality surveillance.
Great, thank you very much also for that question. Really very, very important. And we do want to acknowledge that the rapid mortality surveillance system should not undermine the civil registration system. And we outline in the technical package some of the links also that will hopefully help in situations like the current pandemic to ensure that civil registration can continue and that all deaths that are captured in the rapid mortality surveillance system can be registered with the civil registrar. We do acknowledge that civil registration systems may not always be the best source of rapid mortality surveillance, and maybe a more direct link to, let's say, the health sector to capture all the deaths may be needed in this time of the pandemic. But we do also see the strengthening of mortality reporting from these possible sources that we outlined in the webinar as an opportunity to strengthen the civil registration system. Rapid mortality surveillance will allow the capture of all deaths that occur in communities and in facilities. And this is exactly the information that is required for the civil registration of those deaths. And it would really be great if those two systems can act synergistically also for the long run, so that rapid mortality surveillance can transition into improved civil registration of death. Thank you.
Thank you, Martin. The next question is for Roxana. Can you discuss any limitations in the interpretation or analysis of data for rapid mortality surveillance?
Thanks, Ben. This is a really big question, so I'll try and answer part of it during the Q&A. In terms of the interpretation, as I mentioned earlier, excess mortality would be the additional deaths that have occurred during the COVID-19 pandemic. And as Philip mentioned, this could be directly due to COVID-19 infections or even indirectly and especially as we know that access and utilization of other healthcare services are affected. So it's important to interpret the results in conjunction with other information, especially the implementation of public health and social measures. With regards to limitation, this would depend on the methodology of data collection firstly. So this, as we know, this could vary. In some countries, we may have complete enumeration data with several years of historical information or data, to other countries where we may only have a few surveillance sites and limited historical information. In the case where all-cause mortality is used without cause of death investigation, we won't know the exact percentage due to COVID-19 infections. And without extensive testing, this information will always remain uncertain. And as Philip said, won't provide a true impact of COVID-19 on mortality in terms of the entire burden. Also, for the purpose of the rapid mortality surveillance, we are only collecting a limited number of data elements. So we will not have extensive information on every death. So in summary, I think Martin addressed this in the previous question, a rapid mortality surveillance system cannot replace a well-functioning CRVS system. And so all efforts to improve CRVS systems in general should continue. Thanks, Ben.
Thank you. The next question is for Martin. How do we account for people who die from home and that death has not been notified?
Yeah, thanks for that question. And I mean, those will be very challenging. It will be very challenging, of course, to capture all of those deaths. So again, it's about understanding what are the possible sources of this information. And in the current settings, maybe the civil registration system that receives official notification of death will not be able to capture all death. However, we believe that through an examination of other possible sources of information, it is possible to identify systems that can actually report on all death. This may be through a network of community health workers, or even by looking at, this is more applicable probably in urban areas, that to look at cemetery reporting, which would not necessarily be directly linked to the notifications to the civil registration system, but which would be sources of information that capture close to all death. Unfortunately, also the pandemic is such that even if not every death is counted, in some areas, the excess mortality is still being observed. Thank you.
Thank you, Martin. Unfortunately, we are running out of time. There is a lot of interest and there are some questions that have not been responded to during the webinar. However, we will email those responses to you. So thank you. I will turn it back over to April now.
Thank you, Benjamin, and thank you to the audience for your questions. And again, thank you for staying with us through the technical challenge that we had. It was a great session, and I really enjoyed seeing your responses to the poll. It was a very motivating way to wrap up the session, being able to see that there's a clear benefit to this work in your COVID-19 response. So now, after this time together, we hope that you are better prepared to implement rapid mortality surveillance and to examine excess mortality measurement in the response in your particular country. To do this work together, it is important that we continue to hear from you. Upon leaving this webinar, you will be redirected to complete a brief survey. This is your opportunity to give feedback on this session and ideas for future sessions, as well as an opportunity for us to learn about your plans for using the new technical package, which will launch this week. In the next 2 days, you can expect to receive the slides and a recording of the session, and we will follow up with a link to the technical package and other related resources once they are available. We look forward to continuing this dialogue and learning with you as we address this evolving challenge. Thank you once again to all of our panelists, and thank you all for participating. We appreciate your time and your attention today. Have a good day or a good evening, depending on where you joined us from today, and thank you. Thank you all.